So hello and welcome to this podcast on hyperuricemia and its most important clinical manifestations. First, I'm going to consider hyperuricemia, which is a very important and common disorder of urate metabolism. However, before talking specifically about hyperuricemia, I want to briefly mention the absolute basics of urate metabolism. Urate or uric acid is a breakdown product of the purines. These are a class of nucleic acids found throughout cells of the body and importantly include adenosine and guanosine. Purine metabolism is quite complex but can be simplified into three basic steps: purine to hypoxanthine and xanthine, then xanthine to urate, and finally urate to allantoin. This last step is catalyzed by the enzyme uricase that is importantly absent in humans. It is therefore possible and humans have a propensity to accumulate urate because of this absence, and the most important mechanism of excretion for urate is the kidneys. So let's now talk a little bit about hyperuricemia itself. You can basically divide up the causes of hyperuricemia into those caused by either increased urate production or decreased urate excretion. This is shown in the table on the slide. However, note also that each may be subclassified into either primary or secondary. The primary disorders of increased urate production tend to be genetic, and most importantly include Lesch-Nyhan syndrome and von Geerk's disease. Lesch-Nyhan syndrome is an X-linked recessive disease and therefore only affects males. It is a deficiency of HGPRT, an enzyme that plays an important role in purine synthesis. This condition is associated with three major hallmarks: hyperuricemia, nervous system impairment, and self-mutilism. Hyperuricemia characteristically leads to orange nappy crystals as a baby, then later in life, uric acid stones in the urinary tract, and of course, gout. Various neurological disorders are described and are notably very similar to cerebral palsy, and include hypotonia, developmental delay, and later chorioathetosis and dystonia. It is worth noting that many children with this disease are misdiagnosed as suffering from cerebral palsy early in life. Finally, self-mutilism tends to occur by 2 to 3 years of age. Von Geerk's disease, on the other hand, is an autosomal recessive glycogen storage disorder that is characterized by the deficiency of glucose 6-phosphatase. It also causes hyperuricemia, but two other important signs are fasting hypoglycemia and hypolipidemia. The one other primary cause of increased urate production is, of course, intake, with high dietary purine intake in, for example, foods such as offal, sweet meats. Secondary causes of hyperuricemia can basically be anything that increases cell turnover. Important examples include lymphoma and myeloproliferative disorders, particularly in the context of treatment with cytotoxic agents. This condition is known as tumor lysis syndrome and is characterized by severe hyperkalemia, usually greater than 7 millimoles per litre, hyperphosphatemia, hypocalcemia, and hyperuricemia. Both hyperphosphatemia and hyperuricemia can lead to acute renal failure. In addition, various inflammatory and autoimmune phenomena are also associated with increased cellular turnover, and examples to watch out for include psoriasis and hemolysis. So let's move on now to disorders of decreased urate excretion. There is only one primary disorder here that you need to be aware of, and this is incredibly rare. This is FJHN, or familial juvenile hyperuricemic nephropathy. This is basically an inherited disease of the kidneys, characterized by altered uric acid tubular transport. This results in early onset of gout, kidney failure, and reduced concentrations of acid in the urine, so that's hypouricemia, and elevated concentrations in the blood, so hyperuricemia. Secondary causes are much more important in this category and include chronic renal failure, hypoparathyroidism, and various drugs and diuretics. This leads nicely on to a discussion of some of the most important drugs that cause hyperuricemia. The most important ones have already been mentioned and include the cytotoxics. However, other important drugs are diuretics, namely thiazides and furosemide, but also aspirin in low doses and sulfonamides as well. Importantly, the effect of different doses of aspirin is rather paradoxical, i.e. low dose tends to lead to the retention of uric acid, while high dose tends to lead to uricosuric or secretion of uric acid. This is actually of little practical importance, and most patients can be started on aspirin at a low dose quite safely. So let's move on now and talk a little bit about some of the most important manifestations of hyperuricemia. The most important one by far is gout. However, remember that as well as potentially being totally asymptomatic, hyperuricemia is also associated with nephropathy and the formation of urate calculi in the renal tract. So now I'm going to go on to talk a little bit about gout and pseudogout. The first thing to understand about gout is that not all hyperuricemic patients will develop gout. In fact, it has been estimated that the figure is around 5%. This is a very famous picture drawn by James Gilray that illustrates some of the most important features of acute gout. Clinical features include the sudden onset of pain, and the most common joints that are affected are the metatarsophalangeal joints. This tends to account for about 75% of cases. But other joints that can be infected include the ankle, elbow, and indeed fingers. The presentation, when you look at it, is of an acute red and hot swollen joint. In terms of investigations, it's important to do some blood tests as well as a joint tap. In terms of the bloods, you can see an elevated urate, which would make you think of gout. However, note that the serum urate can be normal during an acute attack, so gout mustn't be excluded based upon this finding. Going with inflammation, you'd see leukocytosis as well as a raised CRP or ESR. The joint tap is practically diagnostic, and you're looking for low viscosity and an increase in the white cell count that is sterile. You also want to do light microscopy, and characteristic findings are needle-shaped crystals that are negatively birefringent. In terms of management, during the acute attack, all the most recent evidence points towards using non-steroidal anti-inflammatories. Good examples would include diclofenac, indomethacin, and naproxen. Colchicine was traditionally used, but is now reserved for patients who are not able to take non-steroidals, including patients with peptic ulcer disease or bad hypertension. There's also considerable evidence for using both oral steroids in the acute attack and intra-articular steroids. In terms of the management of chronic gout or chronic hyperuricemia, this should be considered in the context of recurrent attacks, tophi, or severe hyperuricemia. Therapy is based usually around allopurinol. This is a xanthine oxidase inhibitor that reduces the formation of xanthine and hypoxanthine, if you remember from our pathway. Another drug that we can use is probenecid, and this promotes renal excretion of urate. So finally, I want to talk just briefly about pseudogout, mainly to differentiate it from gout itself. Clinically, pseudogout looks a lot like gout. However, it varies both in the population of people it tends to affect, its presentation in those people, and the type of crystals that are seen with light microscopy. So in pseudogout, instead of having your negatively birefringent needle-shaped crystals, you'll have brick-shaped, positively birefringent crystals. Pseudogout tends to occur also in patients with osteoarthritis, who are often more elderly than the patients who present with gout. Also, pseudogout tends to affect larger joints. Finally, shown on this radiograph of the knee, one of the characteristic features of pseudogout is seen. This is chondrocalcinosis. So that basically completes this podcast. We've had a very brief look at basic urate metabolism. We've gone through some of the most important causes for hyperuricemia. And finally, we've considered one of the most important manifestations of hyperuricemia, that is gout. I've also tried to differentiate it from pseudogout. So that completes this podcast. Thanks for listening and subscribing, and see you soon.